Good afternoon. We're going to start. Welcome to the Interdisciplinary Research Conference for 2015-2016. We're going to start with Dr. Matthew Mitchell and Sara Orbe, and they're presenting on mechanisms related to exercise-induced reductions in cancer-related fatigue, an 8-week exercise program.
Good afternoon. Really great to have you here. I get to share some of our results from our research with cancer-related fatigue. I want to make sure before we get started just to acknowledge so many of our volunteers that have helped in our program. Dr. Sylvester, who's run our program for a few years now, really the brains behind what we do. Today we're going to share some of the research that's been going on in our program and also in our human performance laboratory, where we've been getting at some of the mechanisms behind fatigue and what exactly is going on there with the influence of exercise. Sara Orbe, she's one of our undergrads in our department, has really kind of taken the reins as far as a lot of research we've done both in the lab with testing our subjects, and so she's actually going to share a lot of what we're doing, what our program is like, and then on to our data and some results we found. So, Sara.
Hello. So let's start with what cancer fatigue is. Cancer-related fatigue is described as a distressing physical, emotional, and cognitive exhaustion that's not proportional to sleep. So you might go to bed one night at 3 a.m., you're studying for an exam, and wake up the next morning and be tired, exhausted the whole day, but it's completely different than what these patients are going through. They have an exhaustion that isn't cured by sleep. They might sleep for 15 hours a day and still feel tired. CRF is currently classified as the most distressing symptom experienced by cancer survivors months and years post-treatment. So that's including chemotherapy, radiation, the pain from the cancer itself, and everything else they're going under. They find that this fatigue is the most distressing. So imagine just feeling tired all the time and how awful that must feel. CRF occurs in 70 to 90% of patients, and the fatigue experienced by those diagnosed with CRF is unique and distinct in comparison to fatigue in other settings. So like I said earlier, you might feel tired one day because maybe you went for a run or you had a really hard workout and you're just like, oh, I'm so exhausted. But it's a completely different fatigue. The fatigue these patients are suffering with is total mind, body, everything. So let's look at some of the prevalence. It's prevalence in about 40% of the 12 million cancer patients diagnosed. So that's a really large number. And they claim to have persistent fatigue in the past month. So persistent fatigue is defined by the National Comprehensive Cancer Network as 2 consecutive weeks in a 1-month period. So that's half of the month, feeling completely exhausted. 33% of survivors still claim to have symptoms despite being 5 years post-treatment. So imagine 5 years, that's finishing college, and you're still fatigued, even though there's no cancer, your PET scans are clean, there's no tumors, there's nothing, and you're still tired. 98% of patients diagnosed considered fatigue to be the most distressing symptom they experienced before and after treatment. Like I explained earlier, considering everything that they've gone through, this fatigue takes over their whole body, and it's so distressing. So let's look at some of the mechanism behind this. So first we have the cancer itself. So your cells are being metabolized differently. There's growth going on. All this stuff is going on in your cells, causing fatigue to your body. And then we have cancer treatments. So whether that's radiation or chemotherapy, a lot of studies found that there was a sudden onset feeling of fatigue. We have pain. So this one's kind of interesting because it makes me think of bone marrow. So a lot of patients have to undergo bone marrow transplant. So imagine your bone and taking a scalpel and just going through the inside of your bone to get out these red blood cells. And so that's a really painful experience. So that alone is causing fatigue. We also find anemia in about 7 out of 10 patients. So that's when there's not enough hematocrit in your cells, and that's what brings the oxygen to your other cells. And so, just imagine running. There's a lack of oxygen, you feel tired, you feel fatigued. So now imagine that amplified in your cells. So there's not enough of that, making you tired. And there could be fatigue before treatment. So whether that's coming from living an extremely stressful lifestyle, you know that, like we said earlier, there's about 12 million patients diagnosed with cancer. Everyone knows that most people are living a stressful lifestyle now, so they have that tiredness. And then on top of that, now they have to undergo therapy to get rid of this cancer. there's other medical problems. So a lot of times in our patients we see comorbidities. So whether that's arthritis, they might have a coronary heart disease, diabetes, obesity, all of that by itself causes fatigue. So then once you put the cancer on top of it and everything else they're going through, they're extremely exhausted. A lack of physical activity that makes you feel lethargic. There's nutrition problems. So as many of you know, when someone's going under chemotherapy, they become extremely nauseous. So because they're so nauseous, they're not able to eat, and they actually go into cachexia, which is a lack of nutrients and caloric uptake in your body. So their bodies begin to feel weak and tired. And so another reason, some medications. To treat the nausea, sometimes patients take prednisone, and prednisone showed that there's about 30% of patients taking that who feel extremely fatigued. And then emotional distress, whether that's depression coming pre, post, mid-treatment, whatever they're going through, that just adds to everything. And we also see a lot of sleep problems in our patients. So they might have some insomnia, whether that's caused by stress, maybe it's caused by medications. All of that is going into this complete and total exhaustion. So let's get behind some of the mechanisms. So studies have shown that there's an increase in brain serotonin. And when there's an increase in brain serotonin, there's also an increase in their 5-HT receptors. So that makes your body feel like it's doing a lot more work than it is. So you might go and grab a glass of water or walk to your mailbox, but feel completely and totally exhausted, like you just ran a marathon. Another thing studies have shown is that there's a modified HPA axis, and that's your hypothalamic pituitary adrenal axis. And that's in charge of telling your glands to secrete certain things. So it tells your gland to secrete cortisol to give you a spike of energy to go and do something you need to do. And then with that, we see changes in cortisol. So the modified HPA axis isn't producing enough cortisol in your body. And when there's not enough cortisol in your body, you feel fatigued. You're not able to do stuff. And then we also see immune system dysfunction. So whether that's a lack of T cells, there's stuff going on with the cytokine. So all of that in itself is causing fatigue. And lastly, we see dysregulation in ATP metabolism and regeneration. So if you picture the cell, and everyone knows this, that in the cell there's the nucleus and the mitochondria, and the mitochondria produces ATP. And so that's not being produced properly, so there's not enough energy in one cell and then the rest of the cells. So how can we fix this? Doctors like to fix this non-pharmacologically first. So a really great way, and this is what we do at PBA, we have an exercise program. You can fix it through nutrition. You can fix it through therapy, whether that's counseling, art and music therapy. A lot of patients said that meditation and yoga actually helps them feel more energized. And then lastly, the doctors will go to pharmacological treatments. So here we're going to talk about Palm Beach Atlantic's CRF program. So it's an 8-week exercise program where we take volunteers and they work one-on-one with a patient. So it's kind of like a personal training system. We bring them in, you work with them the whole entire 8 weeks. You really get to know these patients. It's amazing. And then we start them with about 10 to 30 minutes of cardiovascular training. So whether that's the elliptical, the track, the treadmill, we just want to get them moving. And you might think like, oh, 10 minutes so easy, I can walk for 10 minutes. But these patients really can. It's difficult for them. They have to go from being completely exhausted to now walking all the time. We also do 20 to 30 minutes of resistance training just to build some muscles in them. So whether that's bicep curls, leg press, hip abduction, building up all these muscles to give them back the strength that they lost through cancer treatment. So here's some great pictures of our program. That's Dr. Sylvester over there. Like we said earlier, this is his child, his baby, that he came up with this program. It's an amazing program. And here's some volunteers. So what did we study? We were studying the changes in blood lactate levels using a lactic acid analyzer. So lactic acid is what builds up in your muscles when you begin to feel fatigue. So you might go for a run or you're squatting really heavy weights and you begin to feel tired and there's an increase in lactic acid. So we did a little finger prick with our patients before they exercised. We did that 3 times and it came up with a number. We also studied levels of perceived fatigue using FSI scale. So that's our fatigue symptom inventory scale. That's a 14-question self-test that patients filled out every Friday, and it would ask questions like, on a scale of 1 to 10, how did your fatigue affect your daily life this week? And they would scale it. We looked at changes in strength using an isometric dynamometer. So you can put this dynamometer on a specific muscle, and you can test the exact muscle strength in that muscle. So we did it on biceps, and we did it on the hips. We also looked at changes in cardiovascular endurance using an EKG monitored machine. And then we also did a graded exercise test. So that's when you start off walking slowly, and then it slowly increases up the grade. So here's a better picture of how we did everything. So T1, this is when our patients first come in and they haven't done any exercise whatsoever. We have them fill out their informed consent. We go over medical history with them. And then this is when we do our EKG stress test. So we have a stress test and an EKG in our lab. We get the patients coming on the treadmill, and we start them off at 2 miles an hour. And you can just imagine 2 miles an hour is really slow. But we have plenty of patients who weren't able to do that. And we slowly started increasing that, and we looked at how their heart responded. We also measured their resting blood lactate and their muscle strength. Midway through the program, we did another strength test, their lactic acid again, and then lastly, we did another EKG test, muscle strength, and blood lactate, and we looked how all of that worked together. So here's what we found. As you can see, there's a significant decrease in the fatigue scales from the first week all the way to the midweek, and then down to the last week of the program. So that was really great to see. And then you can see that there was an increase in strength in all of our patients. And then here is the blood lactate. So it started off at 5, and then midway through the numbers went up a bit, and then it went down a bit. We think the reason this went up is we did have a smaller sample size. This was only about 6 people testing their blood lactate. So radiation, chemotherapy, and other stuff really affected our data. But we could see that it did go down a lot. And other findings, we found that the changes in resting blood lactate were moderately correlated to the cancer fatigue scales, so that was great, with a R value of 6.38. There was no changes in resting exercise heart rate. There was no changes in resting exercise or recovery blood pressure. And we didn't find any changes in the graded exercise test. So I'm going to hand it off over to Dr. Mitchell now.
One of the things to share, so I get to share with you some of the behind the scenes a little bit, and also where we're going future-wise. Some of you, even if you're not familiar with our research, you can probably guess, gosh, you must have a lot of things going on with these patients. You know, the cancer patients, they're undergoing treatment, a lot of difficulties, and you'd be correct. And so we're well aware that the data, I don't know if muddy is the correct word, but there are definitely a lot of other things going on, and it's definitely a struggle. So sample size for us has always been a challenge. To give you an idea, in our program, we usually initially assess about 15 subjects a semester. We're fortunate if we can get 10 in the program, and that's after physician referral, after our assessment, physical therapy assessment, after graded exercise tests, assuming there's nothing out of the ordinary, then letting them in the program, then assuming they stick in the program, which is an assumption to say the least. Not uncommon for our subjects to go back into treatment, have other issues go on, even some of these other comorbidities also occurring over these 8 weeks. So when we look at our data, we're actually excited, particularly about the fatigue, some potential with blood lactate, even given our fairly small sample size. So we're excited about that, but definitely issues, and we really are thankful. So many of our volunteers, I know some of you are students in here who volunteer, they really are the day in, day out part of what we do. It's the undergraduate volunteers that help with working with subjects every day, working within the program every day through getting heart rates and blood pressures and pulse ox saturation, to walking through the program, to making sure they get rest, to bringing them into the lab. So when we do tests, a number of you also help with our graded exercise tests. So this has very much been a student-driven project, which we're excited about, probably as much as anything as far as the data goes. With that, here's where our future line is going, and we're excited as a lab. This is really our first year we've really dug deep into looking at mechanisms, and blood lactate for us was a fairly, I don't want to say easy way to go, but at least testing-wise, a simpler way to go. Our next steps here, we're really interested in some of the changes in hypothalamic pituitary adrenal axis. We're partnering with the Gregory School of Pharmacy. Hopefully next semester we're getting a grant for that, we're hoping, to look at cortisol and C-reactive protein to get some sense is, are we seeing some changes with exercise in a marker of the HPA axis and some inflammatory markers. A lot of things here we'd love to look at future-wise. Cytokines, particularly IL-6, TNF-A, there's a decent amount of research out there that says IL-6 specifically not only has a pretty large role in this fatigue, that exercise may have a larger impact on IL-6 than probably anything else immune system-wise. So that's probably a few years ahead for us, but another thing we're excited to look at. Alterations in ATP synthesis is another area. Some of my students, you know that too well when we talk about metabolism, glycolysis, and oxidative phosphorylation, fun times. And so potentially looking at some of those mechanisms, maybe what's going on specifically in the mitochondria, is another step we're looking forward to probably later on. Also look at comorbidities. Simple things that we know are issues in our subjects: anemia, poor nutrition, other musculoskeletal issues, renal insufficiency, are things we've large part kind of, I don't want to say ignored, but have been focused more on the subject getting through exercise, not some of those comorbidities. And so some future research we want to look at is, so what role do they have? How extensive is anemia in our subjects? How poor is nutrition? And those are areas that we're looking forward to in the future. Last, but certainly not least, and a little different direction, we've been blessed to have our Human Performance Laboratory, which has really gotten into gear this year. And part of that is we're now able to do what we call gait analysis, which is a 3D motion camera capture analysis of someone's walking gait using high frame rate video. And it helps us a lot to get a sense of, are there some abnormalities in someone's gait, stride, walking pattern. More of a biomechanical side to this. Now, the reason we're interested in this in cancer fatigue is a lot of our patients not only have cancer, but their physical ability is very limited. To give you an idea, I would, in fact, just looking at our graded exercise test data, about half of our patients have a functional capacity that's about 5 METs. To give you an idea, 5 MET, that equates to about 17 milliliters of oxygen per kilogram body weight per minute, which is probably what it takes most of you to walk a flight of stairs, to give you an idea. So about half of our patients really can't walk a flight of stairs, which is a problem because our lab's on the 2nd floor. Always an issue. And so being able to assess, okay, is there a way through our exercise we can improve gait, not just strength, but improve gait, reduce some abnormalities where maybe simple things like walking up the stairs, they can not just become stronger, but maybe more efficient. And that's helpful when, for some of these subjects, simply walking to the mall, walking to their car are very difficult tasks. And so that's something, hopefully next year, we're looking at measuring, assessing, are we seeing improvements in gait in these subjects? And something we're excited to see. So, any questions?
Yeah, Jim. Fascinating. Are these subjects actively undergoing chemotherapy?
We have some who are still undergoing chemotherapy, and then we have some that are a few years post-treatment, but all of them have given the go from their physicians and whatnot, and they know that they're going through this exercise.
That sounds like 2 radically different populations, you know?
Yeah, you're right.
I mean, I would think just to be able to get that huge variable out of the way, if you could get just subjects who were clearly done with their treatment phase, because you had about a third of patients, I have no idea, 5 years after treatment, still feel chronically fatigued. You know, that's a little bit more, at least, homogeneous population, but I guess that's easier said than done. You know,
Absolutely.
Yeah, I would say, you know, one of the challenges, Jim, for us is, you know, we we started the program to really, how can we assist individuals in the community struggling with this fatigue first and foremost. And so balancing, we want to improve their mental and physical health. And you and I know we want to do research, we want it to be quality. We want to get some data that we can say, hey, this is how this is working, this is a mechanism that we're seeing improve. And we are still small, we're working on improving that. But you're right, and that's a big challenge for us. Yeah, without a doubt.
Quick question with exercise and regimen. Do you kind of like have a check sheet in a sense where they have to go through the same thing? Or are you thinking of switching up some variables in a sense? Or is it tailored to a different individual, a different capacity?
So they're definitely tailored to the individual. So we have many of these people here are volunteers in the program. So it's like you're working with a personal trainer. We have this exercise sheet where it's like, okay, I need to do 10 bicep curls, 3 sets of 10, same thing. And so the volunteers check that off, and we slowly start to see their increase in strength. But at their initial assessment, Dr. Sylvester goes through them. He goes through their medical history, so whether they've had a hip replacement, something's wrong with their knees. So each exercise program is tailored to them to make sure they're getting the most optimal exercise.
And second, a couple. So
Sure, yeah.
Do you measure, in a sense, how much oxygen, in a sense, are you using? Do you kind of give like a little score at the end of the day?
Yeah.
Or?
We don't directly. We actually do have a means where we can measure maximal oxygen uptake. We actually don't do that with our cancer patients, mostly because of the tediousness of it. If you're familiar with that process, we have a mask, it goes on their face, we strap it on really tight, there's a tube attached, they go really fast. Probably not a place we want to go with our subjects. Now, some research does, and it's something Dr. Sylvester and I have talked about. I don't see us going there right now. I mean, to give you an idea, even our graded exercise tests, which I supervise, they're actually submaximal. And for a couple of our patients, according to ACSM guidelines, they need to be, because there may be some cardiac issues. But even for them, we do it submaximal because the reality is that assessment is to see, can they function in our program without any potential cardiac event. I look at some of our cancer patients, and some can. I mean, we will have some young, we just had one last week, breast cancer, 40s. She runs probably 3-4 miles a day on her own. And then the same day we'll have a subject, late 60s, can hardly walk down the hallway to our lab, and in 3 minutes into the test has EKG changes, ST depression, which is not a good sign. And that's all on the same day, and this is in the same program. And so we've kind of steered away from that. Maybe someday, yeah.
Did that person go to N70 or something after?
Well, they lasted, ACSM guideline for what we use in our lab is if they have 1 millimeter of ST depression, we stop the test. It's a little liberal. It's really about millimeter and a half we could go. We don't need to do that, and so, so we try to be a little more conservative on our side.
Another thing with the lactic acid is picking up in a sense is, so your N's very small in a sense, and you have different ranges of sexes, and they have different range of disease states that come with these and different cancers. Just a contribution in a sense would be, is like look at metformin. Metformin would be a good one. Look at congestive heart failure. Someone's like stage 3, they can have a buildup of lactic acid much easier, because if you can't get it out in a sense, if you can't pump it out of the cells, it's going to build up. So there's going to be some confounders that can come in there. So it's actually, you need like a huge sample size, but you don't have it. But it would be just good maybe in the future, like collectively, is with their consent, is to find what medications they were on, and I could help you out too. Let me know which ones increase lactic acid, and also affect kidney function, and also it would be just good to see, hey, what's going on, and you do sub-analysis in the future after you get like 40 patients after 2 years in a sense.
You're absolutely right, and that's, for us, maybe a good way to view it from our side, and I totally agree with you, is this is kind of our first step into mechanisms. So, and it's a continuing step. This is more of a, hey, this is where our progress is, in some ways, as you shared before, with the hopes of not just improving this, but our next steps as far as looking at some other mechanisms. But you're right, I mean, there are so many other factors. Renal insufficiency, especially in some of these individuals, depending on their treatment, can greatly alter lactic acid values. And we saw that with some of our subjects from T1 to T2 to T3. We would see crazy changes that we know aren't because of what they're doing in the program. Yeah, no doubt.
That would be cool.
Yeah.
Correlate, CPT correlation with cortisol lactate.
Yeah, bigger sample size.
Yeah,
sure,
bigger sample.
definitely. Yeah. Question.
From a patient perspective, what is the difference from the fatigue score from roughly 5 to roughly 3.5, or was it 3.7? So what is that in quality of life?
So 1 is that your fatigue didn't affect you at all, and 10 is your fatigue made you so tired you weren't able to get out of bed. So a 5, I guess, would be in the middle, and then down to 3 is our final. Yeah, so 3.71, so it went down from 5.
So what is the impact of that decrease of basically 5 to 4, 3, whatever you... So what is the difference in what they can actually perform now?
Okay, so a lot of patients say that they find it much easier to maybe go and take their dog for a walk. Or we have some patients who have come in and said, walking to my mailbox is difficult for me. And so going from a 5 would be like, okay, I'm tired midway through the day, and then going down to a 3 is like, oh, my tiredness didn't affect me today. I was able to walk around. I was able to walk to the mall. I was able to walk about the grocery store. Does that answer your question a bit more?
Thank you.
Other questions?